Thank you, ma'am.
Bombay
And I thank the ARC for having me out here. Is the screen visible?
Yes, yes.
Perfect. Right. So I'll be talking about what Dr. Gaurav was telling about just with Dr. Ashu. That we are talking about the Hoffman pocket in different situations, and I would use the Hoffman pocket wherever scleral fixation is required. That is in typically these four cases of the SFIOL or a dislocated IOL back complex, a subluxated cataract, and or an iridodialysis repair. So traditionally, what we have been doing is that we are opening up the conjunctiva, making a scleral flap, and then securing the IOL or the iris to the sclera. So now what will be, so in this, the conjunctiva is open. The scleral flap requires sutures or glue later on to be closed. So this was now JCRS in Dr. Richard Hoffman taught us the Hoffman pocket, where the limbal incision is made and a dissection into the sclera is made to form a pocket. And then you pass the suture through the scleral pocket, retrieve the suture from the pocket, and then secure the sutures with a knot. So this is basically the construction of the scleral Hoffman pocket, where you make a limbal groove and you back dissect it from the cornea to the sclera. It's like an SICS. Instead of going from the sclera to the cornea, we are going from the cornea to the sclera. And that's essentially the Hoffman pocket. So I'll be talking about the Hoffman pocket in two situations. The advantages, we'll talk about that also. So we are talking about a similar case with Dr. Ashu Agarwal showed us a couple of minutes back. And this is the CTR is already placed, and here I'm going to secure the whole bag with the with a mth segment. Now these segments are made from Orolab, and that's how what I've been using regularly. There's no financial interest, of course. And here I use a 10-0 proline, and I put the segment in place. I pass the 10-0 proline through the Hoffman pocket, which is there. This is basically railroading it through the 26 gauge needle. And then after you pull through, you're titrating the sutures. You're retrieving the sutures through the Hoffman pocket, and you're tying a knot. While tying a knot, you have to be careful that you tie it appropriately, and you see that the strength of the knot is maintained. Then you go ahead with implantation of the lens. This was a subluxated cataract, and I've placed a toric lens. With the use of the Varion marker, I am able to place and center the lens appropriately. And here you see in the post-op day one, you can see a very well-centered lens. Now, now on to introduce the concept of using the Hoffman pocket in an iridodialysis repair as well, which is, we don't really come across this situation very frequently. All of us are great surgeons, but in the situation where it demands, when we occasionally do have an iridodialysis as bad as this one, in which this was an SICS hard cataract, and unfortunately the surgeon had an iridodialysis. The first step is just to deposit the iris back in place. The lens is already the IOL is already implanted in the bag, and then I create the Hoffman pocket in two areas. Here you'll see that instead of just
60 seconds left.
Sure. Instead of opening up the conjunctiva, I would prefer to just go ahead with the creation of the Hoffman pocket. And this essentially is the same step: back dissection from the cornea to the sclera, pass the suture through the iris, through peripheral iris, and then go back, retrieve the sutures, and tie in the knot. So what essentially this does is, without the opening of the conjunctiva, it makes the whole surgery quite neat, and it facilitates a better cosmesis. So I would just like to end this, that the benefits of the Hoffman pocket leaves an untouched conjunctiva, no sutures required for the scleral flap closure. There is definitely less discomfort post-op and better cosmesis. Thank you so much.
Very nice. Wonderful videos and a lot of teaching here. Just out of curiosity, for an iridodialysis this size, how many points would you like to fixate it?
At least two of this size. I would fixate it at least two. I would make two Hoffman pockets. I would fixate it at two different points at least.
Would you like to combine it with the pupilloplasty also?
If required, yes, definitely. For all, I would do everything that is required to have a better cosmetic outcome at the end of surgery.
Any questions,
Can I
Gaurav?
make a comment?
Yes,
Can I make a,
I just,
can I?
yeah, sure, Ashu, go ahead. Yeah.
Okay, so just wanted to highlight that, I don't know, maybe some people missed it, that I don't make a scleral flap, it's a scleral tunnel. So if there's no scleral suturing required, and if the sutures just get buried in the tunnel,
I know it's
and except for opening up the conjunctiva a little, I think it works. I have tried Hoffman's, but somehow I'm much happier with this the tunnel.
you're not making a tie, you're just making a groove.
Sorry,
You're just making a groove only. Yeah.
I can't hear you.
You can just bury the
I think the admin can mute Dr. Nitin Balakrishnan because there is a disturbance coming.
Mute, please.
So basically, what I'm doing is I'm making a scleral tunnel, and through the tunnel, the sutures, the railroading is done.
No, you don't have to make a scleral tunnel also. You just have to make a scleral groove.
It's fine. A groove, it's a small groove. I mean, I call it a tunnel because this is essentially a groove, and the sutures get buried in it.
Can I make a comment, Chitra?
Yeah.
Yeah, I do the Hoffman's pockets regularly. The only problem is don't be bothered about the oozing. Sometimes the oozing is a little more, but it becomes all right. Immediate post-operative, it becomes all right. Now on the table itself, we can see the oozing will come down a little.
Absolutely.
Many people are a little apprehensive about the oozing which is there, but Hoffman's pocket makes life so much easier.
So, ma'am, very nicely said, Dr. Mohan. In fact, that ooze is there, but there are two other important points. One is that for people who may not be used to doing this back dissection, the correct plane which is to be maintained. So the depth of the groove that you make initially is very, very important. And then the direction in which you, get your crescent knife. And I noticed, Saumil, that, you went quite posterior. So I was wondering how far behind the limbus are you making your, entries. It's not really required to go that far back because the chances of the bleed are much more. And then the dissection is much more, and the chance of the crescent, coming up superficial towards the end, because, whatever you might try, as you go along the curvature of the globe, you tend to change your depth as you go, the further you go. And before you pass your suture, it's very important to actually check how far your pocket has gone, maybe even mark it externally. Otherwise, if you pass your suture beyond the, say a place where your pocket ends, you may have a suture passing through full thickness and you may not be able to retrieve it very easily. So all these small little pearls are very important. And I noticed that your pocket was quite wide. I mean, it was almost like 3 mm or 4 mm. I usually make just a small 2 mm and a 2x2 or 2x2.5 kind of a thing, and it works well for me. So I don't have to dissect very much far behind, and now not like the wider extent of the limb. I mean, not more than 1.5 clock hours is sufficient.
Absolutely.
These few things I've learned over the years. I mean,
absolutely. So, but only for the beginner surgeons, I would making the Hoffman pocket. I would request them to make a slightly wider pocket than a narrower pocket, because the chance of going through the pocket increases.
Thank you very much, Saumil.
I just want to ask one question. With what, Gaurav, how do you make a 2 millimeters? With what instrument do you use to?
So I
just using a crescent blade, I think, to make.
Yeah, I'm using a crescent. I mean, I just make a groove as much as I want it to be, like a small groove incision on the just inside the limbus, and then using a regular crescent like an Alcon or I'm nowadays using this money. I just go and I mean, I don't calibrate it or measure it as such, but yes, the posterior extent definitely you need to mark so that you are sure that how far you've gone. So I'll go about 2.5 mm maximum, not beyond that. And make sure that I pass my suture through, within the extent of the pocket. Sometimes if you go too far from the end of the pocket, you won't find your suture in the end. It'll be a disaster. So
absolutely, you should know where exactly your posterior limit is there.
And the ooze always settles down as.
So exactly the reason why I shifted to a scleral tunnel or a little deep groove, because all these considerations, especially for someone who's beginning, these are considerations that these are issues that one can avoid if you just, most of us are used to tunnels. Tunnel is something that everyone's done.
I think I'm going to go on because we have 3 very good speakers who have very good videos and a lot of teaching pearls here.
Thank you.
Dr. Rahul, could you share your screen?